Good morning. My name's Michelle Clayton, and I'm Chief of the Division of Child Advocacy here at Children's of Pittsburgh. And it's my immense honor to introduce our Grand Rounds speaker for this morning. Dr. Jennifer Wolford has been a member of the Division of Child Advocacy for 14 years and is an absolute force of nature in helping to ensure the safety of children through her leadership, through her clinical care, and through her teaching. She's an associate professor of pediatrics at the University of Pittsburgh School of Medicine and an associate program director of the pediatric residency program here at UPMC Children's Hospital of Pittsburgh. She's a board certified pediatrician and completed her residency and chief residency at UPMC Children's Hospital of Pittsburgh. She's held multiple leadership roles in child advocacy, in medical education, and in community outreach. She serves as medical director of the Allegheny County Child Health Evaluation and Coordination Services, or CHECS program, and is also director of community outreach and as well as the inpatient clinical director for the Division of Child Advocacy. So she wears many hats and juggles it all with grace. She is the longstanding director of the Pediatric Advocacy Leadership Service Program, mentoring residents in community engagement and in policy advocacy. Her scholarly work centers on child abuse recognition, injury evaluation, and diversity and inclusion in medical training. She has publications in leading pediatric and medical education journals, and we're so excited to hear her talk about this important topic today. I give you Dr. Jennifer Wolford.
Thank you so much, and thank you for the warm welcome. Thanks for making time today to be here. Today, I am excited to talk about medical neglect and how we can better recognize, prevent, and reduce medical neglect by working together as good partners to our community friends. So I have no financial disclosures to make today. And I hope to focus on three objectives, and that is to define medical neglect. But we're going to note that that's going to be different of how we as pediatricians define it as compared to how Child Protective Services may define it and how families may view medical neglect. I hope we can consider also the areas that we fall short in as pediatricians of being part of the village that surrounds children and their health. And this may include a need for a deeper understanding, cultural humility, acceptance, and advocacy, as we are all child health advocates. And finally, I hope to go through practical steps to be a good partner to Child Protective Services and to families when we feel that a patient's healthcare needs are being neglected. So just to review a little bit of the national data, and then we'll get down towards more of the scope of medical neglect. For Child Protective Services, there are 4.4 million referrals annually. And so there's about 3 million children involved with Child Protective Services across the country. The CPS system engages approximately 1 in 20 children in the United States every day. And the number one type of report into Child Protective Services is neglect. I was asked a brief question about the biannual or every 2-year child abuse training that you are required to take for your license. And I do think we could be talking more about how we listen, intervene, document, and collaborate about neglect whenever we're doing these biannual updates. In Pennsylvania, it's one of the few states where we have a 2-tier system. So I have sort of 2 sets of numbers to review. There are more than 41,000 reports into CPS, which is a Child Protective Services. This is the tier where a report comes in where there are concerns that meet the state's definitions of child abuse and child maltreatment. And just for the numbers across our state, that's 112 reports every day. And then the substantiation rate, or what is founded through court or other means, is about 5,000. Of those 5,000, just about 16% are substantiated reports of serious physical neglect, and medical neglect will be a brief subset of that. But additionally, there are 81,000 additional calls coming into our state's larger CPS agency or to the state. And of those screened in reports, that accounts for 21 out of every 1,000 children. So when we are interacting with children every day as pediatricians in Pennsylvania, 1 in 5 children are assessed for a GPS need. That's a general protective services need. These are the reports that come in that says, I'm worried about the child's heat in their home during this cold winter week. I am worried about their medical needs. I am worried about the other basic needs of life to keep the child safe. So a GPS report is also very important. And again, 1 in 5 children are assessed annually for that in Pennsylvania. So medical neglect, as I mentioned, is one subtype of neglect, and it's about 1.4 to 2% of all cases. Each year, there's approximately, and this is across the country, there's about 25,000 to 30,000 reports to CPS specifically about medical neglect. But I'd like us to take a moment to think about that medical neglect is probably very under-recognized and then under-intervened on. The reason being, if there are 3 million reports of neglect for children's basic needs, I think it's highly likely that the child's health needs are vulnerable to just not getting met. So when we think about recognizing and intervening, we really aren't, even if we're making these reports in, or if there's a report for general neglect. We are not really making changes by just making that report. And again, I think we're under-recognizing unmet healthcare needs for children. So let's begin by thinking about the definitions of medical neglect. It actually is fairly difficult to define. There is a key paper from Pediatrics in 2007, and it really sort of outlined that this is the failure to heed signs of serious illness or the failure to follow through once there were medical recommendations. And it gave 5 points to help delineate, does this meet the definition of medical neglect? And that included that the child was at risk for being harmed because of the lack of health care, and that the treatment offered significant net benefit to the child, and that the benefit outweighed the adverse or the side effects, and that this healthcare was accessible and available to the family. And most importantly, I think for pediatricians that I like to focus on is that the caregiver understands the medical advice given. But overall, I'll just say that medical neglect doesn't feel good for anyone. So when the parents aren't able to execute or the caretakers aren't able to get to all the appointments or meet these needs, it doesn't feel good for the parents. Additionally, for a pediatrician who's really worried about a child, it doesn't feel good. But most importantly, it doesn't feel good for the kids. It's really hard to pay attention in school if your teeth hurt and it's distracting you. So when we think about how we're defining it, I just want us to acknowledge when it's there, and what we need to focus on is how we make the kids feel better or how we get them their needs. I will comment that this sort of clinical statement was actually retired in 2022. And it was retired with this sort of caveat that actually the caregiver may fail to recognize or respond to a child's medical needs for a variety of reasons. And that in effect, and it really in pediatrics, when they retired this statement, they said an effective response by healthcare professionals to medical neglect requires a comprehensive assessment of the child's needs, the parents' resources, their efforts to provide the need for the child, and the options for ensuring optimal health for the child. And such an assessment requires clear two-way communication. And I frankly think the retirement of this statement was just a call out to pediatricians to say, lean in, you need to do a little better, right? We need to meet families where they are, and how do we get beyond the building that we are working in order to get this better outreach. So we can talk about what meets the definition of neglect, but I do just want to talk about children that have unmet healthcare needs. And that's about 3 to 4% of all children in the United States. When a child has a chronic medical condition, that number about doubles. So about 7% of children with special healthcare needs have some ongoing unmet healthcare needs that are of concern. And the most common categories are listed there, including dental care, preventive health, medical care, as well as mental health services, vision care, and developmental services. Areas that we know there is a paucity of resources and difficult access to. But there are risk factors that we can identify or that we can be aware of so that we can start to try and break down those barriers. And that includes lower socioeconomic status, lack of insurance, living with smokers, and living with grandparents when controlled for other factors. So where is the line of neglect? At the very top of an iceberg, it would be a child with uncontrolled chronic medical issues showing up in duress to the emergency department due to lack of care. We can all identify that. We see that. And at the very bottom, in the lightest shade, it would be those are up-to-date healthy kids with their biannual dental appointments, which is really hard to do in a pediatric dental office, and their annual well checks are all up to date. But in the middle, there's a big range. And when it tips over into having harm to the child, that's debatable, or they may get lucky, or it's a lower respiratory season. And so that asthmatic may have one less hospitalization. So there's a ton of variation in the middle that I think this is where we can work on reducing barriers and making better contact with families. And when you want to rethink this iceberg, right? I said that the very top is neglect. I'd like you to think about each child as an iceberg. And I would like us to think about, of all the children that come into children's, the ones that my division, and there's a lot of them here today, so I'm so grateful, spend a lot of time thinking about, are the children referred into Child Protective Services for any kind of maltreatment? And between 30 and 49% of those children have at least one chronic health condition or one special healthcare need. And so, and those include also learning disabilities, intellectual disabilities, behavioral impairments. And notably, about half of the children involved with CPS are not on the typical developmental scale, with significant proportions having cognitive, language, adaptive, social, or behavioral impairments. So I'd like to flip the script a little bit and say, rather that you see medical neglect and there are other issues going on and barriers that we'll talk about, I'd like you to think that when you are seeing a child that's missing your clinic appointment, or that there are reasons that are preventable for that asthma exacerbation, that it actually is the tip of the iceberg to say, what else is going on for that child, and where else can we seek to bring community partners in to intervene? So please consider thinking that identifying unmet healthcare needs is just a preview of maybe all the other things going on in a child's life. Okay, so a friend said that I should definitely have case vignettes, and we always want to have a vignette that's positive or that has a good outcome. And I was a little hard pressed, and we can go through the data of why in medical neglect it's difficult. But I will say that this little boy sitting here in this exam room, our exam room, he was truant for online schooling, and his camera was usually off. And some thoughtful school director finally made a report to CPS. And this, just as a preview, this photo is shocking. So if you do want to take a moment to close your eyes, but this is how he arrived to our hospital, right? And so this is medical neglect, but this is a neglect of his basic needs, right? And so there can be, look how he plumped back up. There can be positive stories, but what I want to say is there was something going on that another person recognized that finally got him to the help that he needed. And it's really impossible to separate out medical neglect from abuse or withholding of various other things, that there's lots and lots of gray areas. I do have another clinical vignette next. This little girl showed up in our emergency department multiple times. She had multiple untreated medical conditions leading to what parents said were rumination and weight loss. However, this was in September. In 2 months, this is what she looked like. And in 1 month, this is how she was smiling. So even in front of our eyes then, when there was unmet medical needs being sort of proposed, that actually when we can get to a deeper intervention, it can change the trajectory of a child's life. When we think about characteristics of children reported to CPS for medical neglect, 91% of them do have chronic illness. So there's a lot of kids with unmet healthcare needs and not meeting into the threshold of where we're making the report to CPS. And of those chronic illnesses, type 1 diabetes, solid organ transplant, and prematurity related conditions were of the top. Does disproportionately, and we'll talk a little bit more about this, affect children of color. 83% were Black or Hispanic in this 6-year study. And there's some interesting data here. This is 6 years of just looking at medical neglect reports. 54% of the children they sort of were just keeping track of the reports for 6 years had more than one report in the study period. So that's to say that in year one, if there was a child that was reported for medical neglect, that half the time they were getting another report a few years later. So we can take a moment to identify medical neglect and say this medication needs to be filled. They need to get to their 3-month follow-up. But until we get to the root cause of what the barriers are for families, we're not really fixing the issue. And I do think that I see many people here that I've worked with for years. Sometimes we have to get comfortable with this is how this family is bobbing along. And right now they're swimming, and then other times they're not. And we try to just help keep pulling them along because what we want to do is be connected to that child. But I found that statistic to be very insightful. Additionally, sometimes we may refrain from making a report because we don't want to ruin the therapeutic relationship that many of you with chronic illnesses and subspecialists have worked to develop with the family. But 88% of those kids in that study returned right back to the hospital to get the care that they needed. They did not change. They did not move out to another subspecialist. They stayed within that clinic. So 88% of the kids, again, that had that report returned to the hospital subsequently. And this is what I think is interesting. In this study, there were risk factors identified. Number one was a family stressor in the preceding year. And so there is an opportunity then, especially when we have long-term relationships with families, when these stressors come, that we might be thinking about where their healthcare needs could fall off. Or I understand there's been a family separation. How can we make sure that these new changes don't let us step off of of our medications? Do we need to have inhalers at both new homes? Do we need does one parent need to be on the telephone for the 3-month follow-up because that's going to soothe tempers? Whatever the stressors are, right? How do we then sort of anticipate how to keep the child locked in on their healthcare needs to maximize their health? The other thing that I thought was interesting is that there were practical barriers, whether that is transportation or mom's work schedule, documented in 2/3 of the charts. So we were there making a report for medical neglect, and it was in black and white what the barriers were. So is it neglect, or was it just like, well, we identified it, but we just didn't know how to fix it? So you fix it. Throughout this lecture, I have these little yellow stars with a blue circle, or I'm sorry, a blue square, and it's just a way that we can be more engaged as pediatricians. So the first one I have is to engage the full team, your social workers, home healthcare nurses, the schedulers, the people that answer the phone, to relearn the local resources, to think about, do we have some copy of some clipboard that talks about these remote counties? If your division is going out to Cambria, what are the resources there, right? And so again, engaging your full team, we have such rich resources here at Children's. How do we then think about being experts on what we can do to make it easier for the families to walk in this door? Okay. So what does make the diagnosis? And I will say that there is no one set criteria. Is it 5 missed appointments to your clinic? Is it an 8th DKA admission? And likely, working with our thoughtful endocrinologist, it's probably been a Childline report prior to number 8. Is it undetectable seizure medications? Oops, sorry for the typo there. Is it a 3rd ICU admission for asthma? But more so because the parents have no plans to stop smoking. Is it refusal of vaccines, or is it specifically the refusal of pneumococcal vaccine for a sickle cell patient? Or is it a repeated growth faltering admission, right? I see many PHM colleagues and there are repeat admissions. And so it's, when are we tipping over? We do know as pediatricians that each event can cause significant harm. And at the same time, we want to recognize that still things happen. Kids get sick, right? Or viral illnesses tip you into DKA. So there is no specific criteria that we can use today to say this is who we would report in, or this is where a child needs intervention. It's rather continued relationships, thoughtfulness, and talking directly with families. Where I'd like to point out, though, and we are going to talk about community partners, but of course, I'm one of the child abuse docs, so we're going to talk about Child Protective Services. The definition by Child Protective Services law is different. And so it does not match the medical definition. And so medical neglect is just a subset of serious physical neglect. And this is when it endangers the child's life or development or impairs the child's functioning. And again, in that subset is including adequate medical and dental care. So it's not so much that as pediatricians, we're talking about could a bad thing happen, right? But it's rather, but will it? Child Protective Services professionals can intervene when there is imminent danger. Is something bad going to happen? Can we prevent that? Or more so, and more often it's reactive. Did something bad happen? How do we secondary or prevent it again from happening? So for examples, if this child is not giving medication such as IV antibiotics for a high-risk rule-out sepsis, will they have a life-threatening condition? Well, as pediatricians, we're like, no, but that's the whole point. I'm ruling it out, right? But CPS isn't going to intervene. We can't call them from the ED to talk a family into that. That's on us, right? To talk through the risks and the benefits. If this child does not get into treatment such as dental caries treated, will they have an impairment of function? Some may, right? Abscesses, poor chewing, poor health, weight loss, and others are walking around with dental caries and it's not so painful. So CPS really can't move, or we can't really just say like they need to have their teeth fixed when it's not the direct harm. Certainly we can get to some GPS, they can make referrals, we can try and get some resources in there, but I just want to clarify that there is a rub between what pediatricians would consider medical neglect and what the laws say. So why as pediatricians are we uncomfortable with just getting some good care? Well, again, prevention is the name of the game. And I do think that it's upon us to continue to teach our colleagues about the long-term trajectories of medical neglect, right? So first we miss a diagnosis and we have poor, I'm looking at the graph down the side, poor disease control and failure to thrive. We know there's one time where we've got rapid brain development, which is such early in life. And then that can lead to developmental delays. But when you're delayed, then as you get to middle childhood, now we've got school difficulties and the cognitive gap can widen. Or we may have recurrent crises, which means we're going to be missing school. Or we're going to have a lot of steroids and we're going to be an overweight child. And now we've got school withdrawal or bullying. And then that perpetuates into adolescence with poor illness and self-management and other mental health behavior concerns and high-risk behaviors. But in adulthood, then it's earlier chronic disease, educational and economic impacts. And then also there's then intergenerational repeated involvement in the systems as both a child whose medical health wasn't taken care of, and then maybe when they become a parent. And so I do think that we have an opportunity for teaching that the small impacts we want to make now can have vast, lifelong trajectory changes. But the CPS threshold is a focus on safety, not just clinical optimization. And so we just have to continue to figure out how to meet in the middle. And again, not all medical adherence actually meets the definition of medical neglect according to CPS law. So again, we're going to have these really high ideas of what children deserve, and they have a right to that health care. And we're going to somewhere have to figure out where are the systems to hold up these kids. That's not just about, it's against the Child Protective Services law. Again, I think I've chatted about this, but the rock and the hard place, a pediatrician's perspective versus CPS law. So for example, I've talked about many of these, but prevention matters to us, vaccines. But one of the reasons that vaccine refusal is not part of, is not child line reporting is because preventive care is not mandated in Child Protective Services law. Or we may say without early intervention, they may develop language later in life, but we recognize that those consequences of late language development are stacked up higher. And so, again, I would say that as pediatricians, we need to reach out to commit to helping others understand the risks and the dangers of the lack of care. So that would include our casework friends, but that would also include families. And they're going to depend on us as pediatric partners to help to understand the severity, the prognosis, and the risk of non-adherence. I would like to challenge us to think about CPS as one partner for children when you are concerned about unmet healthcare needs, and it's time to look at the village. And this is actually on my house last night, and I think it's on this morning again. But it's the Grinch, right? Looking down into Whoville, and he doesn't like it. And I just want to say that, are we the Grinch, or are we actually in the circle? And so we are part of the village, and that's where I would hope that we would get to. So we're going to move on to the second objective. Again, thinking about where we fall short as pediatricians to be part of that village and how we can work towards a deeper understanding. So I have data to review with you, which is a survey of CPS professionals' experience and perspective about the challenges of unmet healthcare needs for children. I'll explain it in the next slide, but when I talk about this, there's 3 counties that were involved, but special gratitude to Allegheny County Children, Youth, and Family, because they have taught me so much in their professionalism about how to work with families across my tenure as a CAC doctor. And so I am particularly grateful to them, and I think some may be listening this morning. So this is a survey conducted of CPS professionals earlier this year, and it was 10 questions, anonymous, multiple choice, and there were write-in options. The average level of experience was 8 years in child welfare. The 3 counties that were participated were Allegheny, Westmoreland, and Erie. Of note, one limitation is this is where we have ongoing relationships with, so we could say, like, please fill out the survey. But we also are working with them a little bit more closely. And this includes both caseworkers and supervisors who are going to have even more experience. So I'm going to go through these questions, and one of them is, do you think, and then you can see that there are 3 anchors there. And the first one I'd like to highlight is that medical providers consider cultural or religious factors when assessing parental decision-making about care. And so the red is not at all, and the orange is somewhat, and then the gray is neutral. And ideally, we'd like to be more on the blue side when we're talking about medical professionals. And so there is a conflict between healthcare providers and families at times because we know an awful lot about children's physiology. And so we are going to focus on the physical health, right? I once heard this saying that healthcare thinks it's a planet that the sun revolves around, or something like that, where families have a lot more that they're trying to balance. And that's going to include their religious beliefs, the development and the joy of the other children in the family, what community resources are available to them, in with their financial stressors, the structural inequities that might ignite mistrust, and the family mental health as a unit. And so we will continue to push, right? That's what we're really good at, is how do we optimize the physical health? And every day families are taking in that information and placing it within the boundaries of what their key priorities have to be. The second question is, do you think medical providers do understand the other barriers that families face when obtaining medical care? And we got pretty blue on that one, but we can understand better. And in your view, how often do medical professionals misinterpret family behavior or access barriers as neglect? And there we're pretty orange, right? So we're misinterpreting that there are barriers to the care or to the behavior of the family as neglect. And so these are the factors of medical neglect. And I'm going to return to this slide several times. The first 2 that I would like to talk about are fear of bills, copays, and other costs, and also lack of transportation. So the most common barriers leading families to neglect children's medical care in the United States is financial. It's both the constraints, it's lack of insurance. It's also, there's some other things in this study: lack of appointment availability, transportation difficulties, poor caregiver health, and then again, the competing family demands. The consistently financial barriers are consistently the strongest predictor of unmet healthcare needs. So one of the places, there's lots of places I could plug this, that we can do more is, I'd like to share with you, if you don't know what an Act 52 is. So this is on the children's website. I pulled it up this week as I was preparing these slides. What's an Act 52? And it is simply a form that parents can fill out with another family member. It does not need to be notarized. And it simply says, if I were to fill it out, my mom can bring my daughter to the healthcare appointment and sign for anything she needs to sign for. And it just needs to be witnessed by somebody. And I would like to suggest that one intervention that we may have when you think about transportation barriers or other financial restraints is if there is a grandma or a godmother or a neighbor, that if we for every child that sees a subspecialist here on a routine basis, that they have 1 or 2 or 3 of these on file. Right. So that families aren't turned away at registration because they're not with the right parent, with the one person that can sign or the 2 people that can sign. Again, it's right on the website. But one thing that we can do is guide families to get all those people, uncles, whoever, into the village more closely. Again, so that the barriers or the challenges that families have, that we've got some other trusted adults that can get in there. And maybe mom or dad can be on the phone, but maybe they don't have to miss work then. The highest bar there was transportation barriers. And I just want to point out 2 things: that the Pittsburgh Regional Transit proposed massive cuts of about 40%. The passing of the state budget did help alleviate this, but it is always sort of a threat. So should you not do anything else but simply advocate for continued public transportation? Tell your patients stories when you are given a platform. If somebody asks what you're voting for, or what should be a priority, or where can you get civically involved. But transportation barriers were the number one thing that caseworkers said are an issue with unmet healthcare needs. And then I thought this was really interesting, because when you think about it, most of the patients that are coming in to visit us at Children's are not coming on public transportation. And so using actually Children's patient data, origin data, and sort of some national averages, the average family travels 40 miles one way to reach Children's, with many traveling 60 to 100 miles for complex care. So how much money does it cost a family to come to Children's for one scheduled appointment and a scheduled radiology? So they're going to be here for a few hours. Well, parking is between $7 and $10, and maybe you need to pay a babysitter for the other kids that you left at home. Food, our cafeteria is not that inexpensive. It's not inexpensive. But then there's transportation and the price of gas. And of course, everybody needs a cup of coffee or a Coca-Cola in the afternoon. So to come down to Children's driving 40 miles one way is not it can be cost prohibitive for families, right? Again, when you think about our catchment area, what can we do to sort of reduce that, or at least acknowledge it? So some ideas are just to understand the gas cards. We have some great social workers at Children's, and they're always finagling these. We could advocate for reduced parking fees. We could consider having somebody in our clinics call the family and say, with that MRI and the wait time and then the appointment, you're going to be here for a few hours, like pack snacks, right? Just helping people anticipate what that might feel like. Maybe you just need to stack your clinic with more toys because they need to bring the sibling along, right? So what are ways that we can make it easier to get in the store for families? Another financial burden, again, is the lost wages. And so an Economic Policy Institute study focused on a survey of hourly employees. And this is the mom working sheets overnight, right? These are the people picking up extra hours at Walmart for the holidays. These are what families are doing to make ends meet. And 55% of those workers have no paid sick leave. So if they do not work, they are not going to get paid. So it's going to cost $90 that day, and they're not going to make that $90 back. So looking at just to problem solve, just looking at the data, pediatricians and caregivers have reported high satisfaction with telehealth visits, particularly for cost saving and convenience. Right. And so we were talking about piloting a little telehealth in our division, and I talked about the outlying counties. And after preparing for today's talk, I thought, if this is what works for you in Highland Park, I'll do it. Right. Why not? Right. And so how can we both reduce the cost and keep people at work? Because that's what they need to do. Because the number one issue is financial constraints. Right. Okay. And then I do just think we need to note that a notable expense in Pennsylvania is childcare. Please remember that 34% of Pennsylvania children live below or near the poverty line, and the average annual cost of putting an infant in daycare is $13,000. Interestingly, a semester at a community college is about $12,000. So you may have had 18 years to save for community college for your child, but no new mom has had time to develop a college savings plan for childcare. The cost of childcare is prohibitive for so many families that we have seen situations where they are forced to leave their children in unsafe environments. And that's a different part of our division that we can talk about a different day. But what can we do? We can advocate for universal pre-K. We can talk to families about their healthcare options. I just think we need to learn about it. I just think we need to see how it works. I have been stunned when someone says, so I found this babysitter on Facebook. And you're like, wow, what can I do as a better child health advocate so that that's not the situation we forced your hand? Okay. Okay, so back to our survey. Caseworker, again, remember this is caseworkers providing insights from years of experience, and this is barriers to understanding one another. And the second question that I just wanted to highlight was, how often do you think parents misunderstand what qualifies as medical neglect? A parent that's here in one of our subspecialty clinics is not thinking about like, what's the definition of medical neglect? They are trying to figure out, what do you mean by arthritis, right? What do you mean by asthma? That is what they're trying to figure out. So again, returning to this where the caseworker said it, I just want to point out that the number 2 and number 3 reasons that caseworkers think contribute to medical neglect is that the caregivers do not understand the medical plan, and that the caregivers do not agree that the medical treatment is important or valuable. And this harkens back a little bit to what I was saying previously. There have been many people that will talk to us about barriers to parental understanding of medical care. I just put a lot of stars up because there's so many different ways that we can impact this, right? There's great work being done about the profession, particularly with Maria Say, about using interpreters. 1 or 2 things that I just wanted to highlight is the high cognitive, in the second category, communication barriers and clinical encounters. I can think about these other ones, or if I had to name them off the top of my head as I was preparing, but the fast-paced visit with just a limited amount of time and the high cognitive load for a parent during a stressful moment, a new diagnosis, new medications, realizing you're going to have to somehow get your 3-year-old to use a nasal spray, right? Like this is all really stressful, and that we actually aren't processing as much. So I just think let's give some voice to that or hold space for it. And then the other one at the bottom that I thought was really interesting as we go through these reasons is difficulty accessing or navigating the portal, right? And so many of us use it. I don't know, I think there's like 2 UPMC portals or 3, or there's a UPMC one or there's not, and then there'll be a new one. And that just sounds like a disaster. My husband, who I'm so glad came to hear me talk today, he can't load an app to save his life. I do all the electronic stuff. Sorry. And but so imagine then the difficulty, right? Or you can't remember your password, all of the things. And so these are barriers to parents understanding medical information. Sorry, my thing is taking a minute. That's what I get for calling Mike out. Okay. So again, factors contributing to medical neglect. We've gone through this. There are 2 others that I would just like to mention. That is distrust of medical providers, and I'll comment to that in a little bit. And then caregiver physical illness and substance abuse and mental health. I do want to say that Act 52, right? We know that substance abuse is a disease. We know that people need support. We know that when parents need to focus on their own mental and physical health, that the best that we might be able to at that moment is to encourage who is the village coming closer, right? Who else can get that child safely to that early intervention appointment, to that OT, or to the follow-up appointment. And then again, I'll comment on the distrust of medical providers. So in summary, this survey provides insights that medical care is often not prioritized for families when the financial burdens are overwhelming, when transportation creates barriers, when the caregivers do not understand the plan or don't agree with the plan, or when the family has competing priorities that they're all trying to balance. And I think there's lots of ways for us as members of that village, as members of the community, not as the Grinch standing outside and saying, like, this is neglect and you need to do something, but rather, what are we doing as part of that circle to make this easier? And then finally, our third objective for today is to learn some practical steps to be a good partner to CPS and families when we feel that a patient's healthcare needs are neglected. Practical recommendations. So when we are worried, when we are working with a family and that there is just repeated missteps, or I'm really worried about the lack of showing up for the infusions, or they're late to their surveillance imaging, or to their maintenance chemo, and it's every time it's just by a couple days, but I'm worried about it. So what can we do? So we do need to gather information and we do need to document. Do the chart review and make it a succinct summary. It does not have to be an entire chartectomy. Nobody wants to read it anyway. You don't want to create it. Nobody wants to read it. Make it concise, make it a one-pager, make it so people understand. Timelines can be useful. Seek information from collaborating entities. We had a recent medical neglect case that a TPN delivery had not come to the home in 4 months. I don't know where the TPN was, or or the delivery person wasn't saying like, hey, there was no one there, or last week's was sitting on the porch. Like, not exactly sure, but the child was using both. The formula delivery hadn't occurred in 11 months. So something's not working, right? But we're not getting the feedback loops. We know communication with these sort of DME things can be challenging, but the writing was on the wall before the child showed up with weight loss. It is important to organize a medical team meeting to identify and articulate the problems. Sometimes there's multiple subspecialists involved, and to develop a medically driven plan that's most likely to create a reasonable standard of care, and to be acceptable and doable for the family, and to think about any untapped resources. So we need to do this work, and then we, of course, need to communicate directly with the family. We're going to adapt the plan as much as possible to accommodate the family's priorities. We do need to document the meeting and then provide a visual plan. If it's on a Teams meeting or it's on the telephone, what can we mail them that says, here are the times of the meds. Remember, here's the pharmacy that we're going to send them to. And then I do think it's important for families that we communicate what will be the measure of success. So, it's interesting. We can talk about growth faltering, and in babies, we know how much we want them to gain 20, 30 grams. But I'll say to PHM, or I'll say to my GI colleagues, like, what about this 9-month-old? Or how about the 2-year-old? How are we going to judge that success, right? And it's not exactly clear, but we're going to have to pick something. And then we're going to have to measure that success so that when the benchmarks aren't met, we need to escalate intervention again. And then I think we need to be clear about those expectations and be willing to lean in and monitor the process. And then number 5 is to be prepared to write a clear child line and communicate with CPS if progress is not being made and child safety is in danger. I'd like to say a word about CPS workers. I would like to remind everyone that they are our professional colleagues and they are working for the Department of Human Services. At the end of the day, caseworkers are humans helping humans. They have actually given their entire career to human services. They are not magicians, nor can they just sort of pick up a child and say, here's your new family. And by the way, that's a terrible idea, right? But what I want to say is they have taught, again, as I mentioned, taught me so much, but they are trained in safety assessment rather than in medical decision-making. They have the ability to evaluate caregiver capacity, intent, and barriers. They can collaborate with us for clinical interpretation, and they can focus on building medical treatment plans. What can they do to address it? And I think I've touched on some of these in the previous slide. This is, again, these hard-going caseworkers trying to get ducks in a row. They can develop safety plans ensuring follow-up and adherence. Doesn't mean they're going to get followed, right? But they can work with a family to say, what could feel good to you? One of my great colleagues would say, like, I can make a phone call with a family, and if the central scheduler says our next appointment is March 21st, the nurse, Vicky, will say, I watch mom's eyes glaze over. She's like, sure, that sounds great. What time? 10 o'clock. Sure. Because there's no chance that's getting executed because that mom has competing priorities of how to put the food on the table. But if we might be able to work with, can you come Friday? There was a cancellation. We might be able to work a little bit more, right? And so I think recognizing that families have competing priorities and trying to say more realistically, this is what families are trying to balance. They need to say that to us. When a CPS caseworker is handed the following childline report, it's really rough. And this is a real example. And all this is like this child's appointment was scheduled. They were seen then, and then there was another provider, but the siblings missed their appointments, and then they were canceled. And then the other sibling, and anyway, and the father's a registered sex offender. And like, what do you want this professional to do with that? Right? That's useless, right? This is another child line for medical neglect. I just really appreciate that this medical provider didn't hold back from saying manual disimpaction was performed to remove stool, which confirmed massive stool burden. We know what that means. A caseworker's just grossed out. Like they are just grossed out. They don't know they don't understand that this means a lot of medical neglect, right? But I will say what I did leave sort of in darker print is there were 7 follow-ups. Okay, that's not easy to do. And how can we make that easier? Or maybe we're going to have to triage those. And then this is how the child line closed. Medical workup was reassuring against other medical causes of poor weight gain. But we're worried essentially that she's aspirating. But per report from the family, she was eating by mouth at home. And we want to say like, that child's aspirating. That's really bad. That's not what the caseworker's like, okay, so they're eating. Isn't that good? You want them to eat, right? And you're like, no, actually we don't in this case. So that's not really fair to these professionals who are designed for human services. So I'll just mention that our division is available to help. We can advise and guide on plain language and clarity for reports. We can complete a consult if we think there'll be prolonged CPS involvement. And we're happy to broker introductions with caseworkers and to join you in conversations. For very lengthy hospitalizations, we're sometimes very often in the background because I'm talking to caseworkers, I'm explaining what the progress notes are, but you are leading in your field of expertise, and I am grateful for it. So as much as I can talk with the caseworkers, at some point I do need you to explain the liver disease, or I will need you to explain the ongoing chronic lung conditions. And so we can do that together. And now we're going to talk about talking to caseworkers. So first of all, quickly, what makes a valuable child line report? It needs to be clear. And the most important thing is next steps for this child, what should happen? Do you need the child located and back to the emergency department? Do you need to recommend that this child be seen? Somebody needs to lay eyes on them within 48 hours. And have you told that to the PCP if that's what you think is necessary? And do you recommend that the family schedule with your subspecialty clinic within the week? And have you made room in your schedule for it? Right. I definitely got a report for a child neglect case. And when the father called to schedule, they scheduled the child 7 months in advance. And he's like, so I think I'm good, right? Well, you're not, but we're going to work through that together. I do want to mention that we have a checks team inside the CPS offices, Child Health Evaluation, Coordination, and Support. This began 10 years ago as a pilot of 3 nurses with Allegheny County. We are now a team of 17. They work alongside caseworkers in the 3 counties that I'd previously mentioned every day to identify medical needs, work with families, and to reduce barriers, and to help prioritize healthcare needs and teach every day. These set of nurses and Melanie on admin are an incredible group of people, and I am grateful for the work they're doing every day, helping our human services colleagues understand. So another thing that you can do is reach out to the checks nurses. Again, we're in every county, or we're in 3 counties. We're not in all of them. And when CPS closes, the engagement of the checks nurses, just because of the volume, has to close. So it's not a pitch perfect system, but it's something. And we're finding ways to hopefully impact children's health. This is a different one. This again said, I just want to highlight the final paragraph. This is an improved child line. Next step would include presentation to the ED, admission to be an IV treatment, follow-up for the routine appointments, and weight checks with the GI doctor. And so again, we can make child lines more clear. But CPS gets a report, even a good one, on a Tuesday afternoon. And before going out, they are going to call you and they're going to verify information, and they are obligated to call you. And if a caseworker tries to reach you and you don't want to call them back, at some point the case might be closed because they could never get the collateral information. So when you don't want to call a caseworker back, or you don't want to take the phone call, or you act all huffy that they bothered you, you aren't helping the child. So when you make that report, it's the beginning of a conversation. And you're like, wait, can I talk to caseworkers? I'll tell you, this is what they want to know. They would like to know, what are the concerns? What are the follow-up? They need to actually speak to someone and verify all of this information. And some medical information has to come from the healthcare team, including how will success be defined and met. Barriers experienced by caseworkers when working with healthcare providers, again, from my survey, number one was privacy and HIPAA concern, or one of the key, difficulty obtaining medical records and provider reluctance to engage. And I would like to speak to these. So our medical records are insane, right? And there should be no caseworker that tries to get a 600-page medical record of a child with chronic illness and tries to interpret it. I think a good pediatrician will walk them through that process. So when a caseworker knocks on your door and says, do you want to build a relationship? I need you to say yes, because you've made that report. And are you afraid to? Don't be afraid. Directly in the laws, Child Protective Services laws supersede HIPAA. It's right there. There it is in the laws. And it says that certified medical practitioners can, in circumstances which negatively affect the medical health of the child, we can provide information to the county about the assessment, whether, and again, if it's a GPS, CPS, or they're open for services, relevant medical information, subsequent examinations, treatment of the child, relevant medical information of any other child in that household, if you happen to be a PCP that works with the whole family. And then also highlighted there is parental consent is not required for the certified medical provider to provide this information. So I want you to sit knowing that you can continue to work and talk directly to Child Protective Services workers for the safety of children. And communication, again, from our survey, just to highlight, have communication and collaboration. How often do you have communication and collaboration challenges for CPS and medical professionals in these cases? And there's a lot of orange there. Some of them are saying in almost every case. So what we can do better as part of the village is increase our understanding of the barriers and advocate as community members. We can learn about the resources of transportation, food resources, childcare, tax credits, and other ways to reduce financial barriers to keep families in poverty. And everybody should be running around with blank Act 52s. And we can communicate with caseworkers about your area of expertise, and I want you to feel confident to do that. And then I would just like to comment that in your one more survey question that I wanted to review. In your experience, how do parents typically perceive allegations of medical neglect? And they could choose more than one answer. And so the family said often as an attack or discrimination against them, or as inaccurate or unjustified. And those were the top two answers that the caseworkers perceive their insights. So I can't work every day with the CPS system and not acknowledge the systemic inequities in the U.S. Child Protective Services system. We know that Black, Latin, and Indigenous families are reported to CPS at significantly higher rates, even after accounting for income and maltreatment risk factors. And that also mandated reporters frequently report families with Medicaid insurance or lower socioeconomic status. But what is the impact on families? It increases family stress. It increases mistrust of healthcare and social systems. And it is higher rates of family separation for economically marginalized families that don't have the resources that others do. And then particularly it's when poverty gets conflated with neglect. It's about the lack of resources, the unequal access to supportive services, and then the under-resourced communities. You may have a child that needs home health nursing and you can't get somebody to service the area, right? So what are the tools that we can use towards equity? There's some stars on here, but shift the focus to material support and embed anti-racist practices training for healthcare and CPS professionals. And some of us divisions are leading in that space here. Implement community-led prevention approaches and reduce reliance on reporting for poverty-related concerns. So again, there's lots of things that we can do to increase the equity in our system or to reduce the inequity. So the take-home points for today are never forget that there's a moment where you may be the one person at that moment in a child's life to catch a glimpse of what's going on. That might be the physical exam in the emergency department when we think about all types of maltreatment. It might be in their health assessment of how things are going on. Or it may be in the absence from your clinic schedule that it might be the tipping off point that there's a there's a lot more going on in that family that they could use some assistance. We do not get the opportunity to make a report about medical neglect. We have the opportunity to find ways to break down barriers to prevent it. So we don't get to call it out, we get to prevent it and to reduce it. And then finally, working with CPS includes clear communication, clear language, continued communication, and teamwork. And so those are my take-home points for the day. I would like to thank all of my supports, most particularly my family, Melanie, Vicky, and the checks team, the entire CAC division, as well as the doctor team, my mentors, Dr. Berger and Dr. Squires. And a shout out to all the working doctor moms who inspire me every day by making it look easy. So, or at least they cry with me about it. With that, I think I made it on time, and I guess there's time for a question. Thank you very much.